Okay? Progressively worsening pain and swelling around his anal region for 2 weeks. It's your first day on the job. What are you going to do?
Well,
So, already, 45-year-old diabetic with pain around his butt. What are you thinking already?
What are we saying?
Hemorrhoids,
Abscess.
abscess. There's also been a discharge and a low-grade fever.
Fissure.
You want to know if he has Crohn's disease? You know, if that's something that forms fistulas. Has he had surgery? Okay. A little bit of elevation in his white count. The sugar's 419. I mean, what are you gonna do with that?
Ice it.
You're not gonna rice. You're in the rice. Okay, so you're in the ER though, right? So what are you gonna do?
you're not supposed to drink those. It's supposed to go where you do not drink.
I mean, it would not be the wrong thing to call the surgeon. Okay. They're probably going to want to know if you opened it and just to see if anything came out and did you culture it and that kind of stuff. But if it looks, this is for one thing, this is a diabetic with a sugar of 419. So I don't know that I would try to open it. Okay? All right, so you call the surgeon. And you give him some IV antibiotics while you're waiting on the surgeon.
Oh, yeah, abscess.
And you could give him that fancy new IV antibiotic, right? No. Yeah. All right, let's do some bleeding. Back to the 60s. 62-year-old female. Bright red blood per rectum. So when you see that written on the chart, you know what it is. Started early this morning. It kind of woke her up from sleep. She got up, she just started passing bright red blood. Total of 8 episodes already this morning. Mild discomfort in the left lower quadrant with urgency when she needs to go to the bathroom. She denies any severe abdominal pain or rectal pain. She's had no weight loss or fevers. She's had some incontinence with this because she can't get there quick enough. Never had bleeding before. This is like the first time this has ever happened. Okay, so you're getting a thorough medical history on her, right? She's type 2 diabetic. She takes cholesterol medicine. She has had a colonoscopy before. She had diverticulosis and no other findings, no polyps, no colon cancer then. She doesn't smoke, doesn't drink. Okay. You probably ask her if she has any other coagulopathies, right? You know, any bleeding disorders or frequent nosebleeds. Have you ever had anything like that in the past? She hasn't. Okay. So you kind of quickly screen her for, you know, you take aspirin, you take NSAIDs, you know, see if there could be any platelet dysfunction, right? So she's awake and pleasant, blood pressure's okay, heart rate's okay, she's very stable, oxygen's good, afebrile, so she's pretty happy. I mean, she's sitting there done. She's just really worried because she's bleeding. And she's hemodynamically stable or unstable? Stable. Bowel sounds are normal, abdomen's soft, she's not tender. You do a rectal exam, it does not look like that other guy's. And she has gross blood present. Okay. What do you do with her? So, she's hemodynamically stable based on her vitals, but what else would you like to know? Her volume status appears to be fine. But what else do you want to know? Like, what labs would you order? Right. You want to see what her CBC is, right? Okay. And you check your bleeding time, too. It's is fine. Platelets are okay, so she's not thrombocytopenic. Hemoglobin's pretty good. I mean, that's pretty good for a middle-aged lady. So yes, she's hemodynamically stable. And so what do you do with this patient from the ER? So what have you done for her? You've said, okay, you are bleeding, but your blood count is okay right now. You are stable. We need to find out where the source of bleeding is, but you can go home. Okay? She doesn't have to stay, but she needs to go see somebody like the next day. Okay? So that's the challenge with the ER. It's like you can't keep everybody there, but you have to make it clear to your patient that they need to go. You need to go have a CBC drawn tomorrow. Like you can go home and go to bed, and if you bleed again, it's okay. But you need to go. You need to go get your blood count drawn tomorrow and recheck it. Okay. And if she doesn't have anywhere to go, then have her come back to the ER and get it drawn again. Okay. But she's going to need a gastroenterologist. So probably the most likely cause of her bleeding is what? Probably she has diverticular bleeding. Yeah, diverticular that's bleeding. That's probably what it is. It could be a colon cancer. Probably not, because she just had a colonoscopy like 3 years ago, right? So it's most likely to be bleeding from a diverticulum. Not an infection, just bleeding from a diverticulum. You can also have a Meckel's diverticulum, usually on the right side, that can bleed pretty briskly as well. So there's other ways the gastroenterologist can work that out. They're probably going to scope her. They're probably going to identify the source of bleeding with the scope. If not, though, you can do bleeding scans and things like that. Okay. The other take-home point on this is lower GI bleeding usually will stop. If you will bowel rest, don't take aspirin, don't take NSAIDs. If they're functioning as far as their clotting mechanism, or if they're functioning, they will usually stop bleeding. Okay? Upper GI bleeds can kill you quickly. So you don't have to be as freaking out with a lower GI bleed. And why do you think it's a lower GI bleed? She's urgent. It's always been bright red. She doesn't really have any risk factors for upper GI bleeding either, does she? She's not cirrhotic. She doesn't have a bleeding disorder. She doesn't take a bunch of NSAIDs. So lower GI bleeding will probably go away on its own, and then she needs to be worked on. Okay. 57-year-old male, 12-hour history of vomiting, bright red blood. So now we're throwing it at the other end. That's the other thing you can ask the lady with the lower GI bleed is, have you had any coffee ground emesis? Have you had any nausea or vomiting? Hematemesis, things like that. And lower GI bleed people will look kind of normal, unless they're having ulcerative colitis or they're sick with infectious colitis. But if it's just a normal lower GI bleed, they don't look as sick as upper GI bleeds look. Okay. So this guy has had 4 episodes of throwing up over 12 hours. He's thrown up blood every time. He's nauseated, he doesn't feel good, he's getting lightheaded when he gets up. He's had an episode of melena. He doesn't really hurt anywhere. His bowels have been, pretty normal leading up to this, other than that black tarry wound. So he has hypertension, chronic back pain. He takes ibuprofen, so that should already be making you wonder. He smokes a pack of cigarettes per day, and he drinks 6 to 8 beers per day for 22 years. So when somebody says, I drink a 6-pack of beer, do you drink a 6-pack a week, or do you do that usually to wind down in the evening? So when you ask somebody that, ask them in a way that sounds non-judgmental. Okay? Don't give them the, you do that every day. Don't do that. say, oh, okay, do you do that? Is that kind of how you chill out in the evenings? You kind of crack open a 6-pack of beer, and is that how you wind down? So try to ask them in a non-judgmental way. So they will be way more forthcoming with information if you treat them like that, rather than treating them like that, okay? Always remember your patients are fighting some battle that you don't know about, okay? Probably drinks because he was molested as a child or something. So if you try to think about it that way, it puts in a little bit of different perspective, So now you get a little bit more physical exam. So he's not doing so good. He's not like our other lady, right? Our other lady was happy in the bed, normal blood pressure. This guy is tanking. His pressure's 94/46. He's really not compensating very well either. He is breathing fairly rapid. His oxygenation's still okay. No fever. He doesn't appear jaundiced. Dry mucosa. Lungs clear. Heart's okay for now. Abdominal exam shows distension, liver enlargement. Can't feel a spleen because y'all are not good at it. Rectal exam reveals that he does have blood in his stool, like he says. So the melena wasn't a bottle of Pepto, it was blood. And he's swollen. Okay? So your labs are kind of telling the story here, right? Look at his playlist. Does that bother you? It should. 1.6 on his INR, so he's a little thin. And of course he has liver enzyme elevation, right? Okay. So, is he hemodynamically stable? No. Are you more worried about him than you were the last lady? Yes. And what's the top of your list? Yeah. Okay. So he needs immediate volume repletion, right? Okay. I would automatically start putting him on a IV PPI. Get your CBC and cross and type in for, I don't know, 4 units. Just have it ready. Okay. So he probably needs to stay in the hospital. All right, so you're going to get the hospitalist or the gastroenterologist on the horn. He doesn't need a surgeon, though, does he, at this point? No. Okay. And again, most cases of lower GI bleed will resolve spontaneously, but this isn't a lower GI bleed. Don't let that confuse you when I send this out. This is an upper GI bleed, but again, what we talked about earlier, lowers will usually resolve. Okay. Yes.
If it was severe, I don't know how to word it, but what type of surgeon would do the case? Like, would general do it, or would?
So
I don't know.
So if this guy's got cirrhosis, the first person he goes to is a GI doctor. They can ban esophageal varices and stop the bleeding internally. If he goes to a surgeon, he'll get something like a TIPS procedure or something. But that'll be very specialized surgery. So the first place to go with bleeds is the GI. Okay. Yes.
So the difference between like esophageal varices and a Mallory-Weiss care, would that just be the presence of ascites and liver?
Right. So he's got other signs. The question was, how do we distinguish between variceal bleeding and Mallory-Weiss tear? Okay. Picture this. 22-year-old guy comes in because he was drinking too much, threw up 20 times, and then he bled. That's going to be a Mallory-Weiss tear. And he's going to bleed a little bit, and no melena usually, maybe a little, but not like this guy. Okay. So Mallory-Weiss tear is probably a younger guy, no signs of cirrhosis. probably does, maybe did drink, but it's not an alcoholic. And you always ask, when you threw up, did you have blood in the first time? The first time you vomited, was there blood in it? No, it was only about that third or fourth time I got blood out. That's usually how a Mallory-Weiss tear happens. Okay. So they'll throw up once or twice, no blood, then they bleed and it's bright red. Okay. And again, no other stigmata of cirrhosis. Okay. All right, this lady is 56 years old, sudden episode, yes?
Does your body naturally want to get rid of blood?
It is irritating to the GI tract, yes.
So it usually won't go past
And
it.
usually it's going to start moving out the other end briskly. Yeah. Okay. Sudden episode of hematemesis. Yesterday she had 2 bowel movements that were dark, sticky, and foul smelling. She woke up nauseated, has vomited a small amount of bright red blood twice today, maybe a little coffee ground looking stuff in it. She also feels weak and lightheaded. She takes no routine medicines and denies any significant past medical history. She smokes a half pack of cigarettes per day. She injured her knee last month, has been taking 5 tablets of naproxen twice a day. Is that a good idea? No, you will see this. Just wait. If one or 2 is good, then 4 must be double good. Her knee feels better, but now she's bleeding. Here's the other thing too. The ulcers that bleed are better because they don't perforate, you know. It's these ulcers that people don't know they have, that they haven't bothered. They have a cast iron stomach, so they're just taking naproxen out the wazoo. They don't have any stomach upset, they don't bleed, and then they perforate and end up really sick, okay? So ulcers that are asymptomatic are way worse in the end. Okay, so, yes.
Sorry. So when people say they're taking a medication and they don't know the dose, or they know they take it 5 times, what do you assume? Do you assume the highest dose, or
Yeah, I mean,
like what would you chart? They don't know the dose, just they don't know.
I would just chart an average of what they think they take. You take it a couple times a day. I just document 2 to 3 twice a day or something like that. Just give a ballpark. Just the fact that she's taking it is a risk factor for a peptic ulcer. Okay, so she is pale. She's visibly distressed or alert. She's a little bit tachycardic. Blood pressure's okay. Conjunctiva are pale. Abdomen is soft, flat, no masses. Bowels are a bit hyperactive. She's pretty tender because she's not rebounding or guarding, so we're not worried about it perforating, right? Bleeding ones don't usually perforate. I mean, it's going to usually do one or the other. And you do a rectal exam, because everybody in the everybody in the ER with abdominal pain gets a rectal exam, right? And she's got grossly melanotic stool. So she's orthostatic as well. So the thing here is, don't use orthostatic vital signs. I mean, it's not an absolute guide to volume status, but if you have a bleeding person that's having orthostatic changes in their blood pressure, it's just another sign you need to give them some fluid and pay attention, okay? All right, what do you want to do with her? She's orthostatic. First things first, she's bleeding. What do you want to know? Who wants to know her hemoglobin and hematocrit? So the good news here is she's coagulating okay. Kidney function's fine, but she needs blood, right? Do you discharge her and say follow up with somebody tomorrow? No. What do you want to give her? Probably give her a little bit of fluid first, and then give her some blood. You got to order the blood. You know, it may take an hour or so to get it there. I mean, I don't know. The ER probably has it there more rapidly than they do on the floor. But if you want to wait for her blood type, it might take a little bit. So give her some fluids and order some blood. Okay. So for her, you probably start her out with a couple of units. Okay? You give her a couple of units in the ER. She'll feel better, for sure, after she gets a couple of units. Okay? So, she's volume depleted, right? Is she? She's orthostatic, so she's probably volume depleted, right? Overall. Her hemoglobin 7.3, what do you think about that? Once you give her a unit of, or a bag of fluid, what do you think is going to happen to the hemoglobin? Yeah. Her hemoglobin may really be 6. Okay? So after you give her a unit of, or give her a bag of fluid and give her more volume, her actual hematocrit may come down. Okay? So then you'll definitely want to recheck it after you give her some fluid. All right, so we're going to admit her, transfuse her, and do serial H&H, see where her CBC goes. And what's the most important thing for her? Stop the naproxen, right? And the PPI. You can give IV Protonics, IV Nexium. Okay. Here's some change in bowels. 19-year-old female. This is non-localized abdominal pain and diarrhea, nausea, can't eat or drink, she's really thirsty. 5 days ago, she returned home from a camping trip in New Mexico. While camping, she only drank bottled water, but she denies fever, but reports some chills. Her stools have been watery brown and profuse with no passive odor. No prior health problems, she's pretty healthy. No alcohol or drugs, no smoking. She looks dehydrated, okay? She doesn't feel good, she's got a bit of temperature. Heart rate's up a little because she's compensating for her volume depletion, right? Soft abdomen, so we don't see guarding, we don't see rebounding. She's just kind of diffusely tender. Not severe, no blood on the rectal exam. So, do you trust her that she's not pregnant? No, we're going to order a pregnancy test. We're going to check her menstrual history to make sure she doesn't have any history of endometriosis or ovarian cysts or problems like that. But she's got a high white count, so what are we thinking? She's probably got some type of infection. Pregnancy test negative. So the specific gravity is high. High is dry, right? Okay. All right, so what do you want to do with her? You confirm that she's not pregnant. Her abdomen's non-localizing. She's got an elevated white count, tiny bit of fever. Yeah. So you don't have any real signs of peritoneal, you don't have signs of free air or perforation. So you don't necessarily need an x-ray. Early on, you probably x-ray almost everybody, and that's okay. You don't have to. For her, you can just tell her she picked up some stomach bug, give her, maybe send her with some flagyl in case she got something out while she was camping. Check the stool culture. She doesn't have any signs of dysentery. Check for fecal leukocytes. You can send her home and have her follow up about these things, okay? But what does she need in the ER? She needs fluids, right? You give her fluids, treat her vomiting, give her some Zofran, so give her a little fluids, a little Zofran, tell her she'll be better in a few days. And you can check the stool things if you want. Okay, we're going to have to go fast through these. Okay, now we got a 78-year-old. I'm not even going to spend a whole lot of time on this one because her family's bringing her in, telling her she's not being taken care of in the nursing home. When they check on her, she always has poop in her diaper. It smells terrible. What does she have? Let's see it. Okay. She's got elevated white count. Platelets are normal. Sodium slightly decreased. Union creatinine ratio is high. Okay. So she lives in the nursing home. She has C. diff. Okay, but you assess her for volume, right? Blood pressure, cap refills, skin turnover, all that kind of stuff. Make sure she's not full of fluid in her extremities, the lungs are clear, this kind of things. Okay. 2.5-year-old, female, brought by her parents. Severe stomach ache, she's been crying for several hours off and on, she's not eaten since yesterday, she's vomited twice since the pain began. The last normal bowel movement was 2 days ago. Today she passed a weird stool that looks like bloody snot or jelly.
Interception.
Yes. They're worried because she won't eat or drink. Okay. She's otherwise been normal, she's up to date on her vaccinations. Okay. So how do you assess intussusception? This x-ray is terrible, but I mean, you'll see air above it on an x-ray, so you'll see that she's got an obstruction. And then if you are really good at ultrasound, you can see the target sign. Yeah. And so what is both diagnostic and is the treatment? Air contrast variant enema. So you can see where it's intussuscepted on itself right there. So you'll see that coiled spring where it looks like it's it's riding in on itself. Okay. You have to make sure there's no signs of perforation before you put contrast in anyone, right? The belly's soft, bowel sounds are normal. This will both diagnose it, confirm the diagnosis, and reduce it usually. Okay? 73, 2-day history of small semi-form weird stools with a lot of urgency. Mucus mixed with blood at times. Generalized stomach upsets now localized to the left lower quadrant. Never had a colonoscopy, never had symptoms like this before. No family history of colon problems. A little bit of chills, no fever, but it probably hasn't taken it like most 73-year-old men. No night sweats, weight loss, mild nausea, just kind of didn't want to eat like normal. You screen him for urinary stuff. He's got no dysuria, no hematuria. He doesn't have gynecological organs, so we don't have to worry about that. So we got left lower quadrant pain. Doesn't feel good, doesn't want to eat. Anybody want to know if he's febrile? Got a little bit of fever. Not really dehydrated. He's really tender in his left lower quadrant. He didn't have any signs of distension, guarding, rebounding, any of that. No signs of cirrhosis. Stool swag negative. What could this be? You're already thinking diverticulitis, right? What else could it be that you don't want to not find? Say again. Colon cancer. Fever kind of points you towards something infectious, which is helpful. But a lot of older people don't run a lot of fever. So let's say his temperature is normal. Well, you want to worry. You could maybe wonder about it being vascular too. The other thing you want to kind of keep in your differential. So you've got the diverticulitis, as my patient called it. Diverticulitis. Okay. So his white count's up. Everything else is fine. They can actually get a pyuria with diverticulitis too, especially if it's really low, because the bladder and the rectosigmoid colon blade is right there together. It's kind of weird that it'll do that, but it can happen. All right, 79-year-old male, 1-day history of severe abdominal pain, loose stool, intermittently bloody. So it's kind of like the other guy. Weird stool, urgent, loose, but this one's intermittently bloody as well. This one's kind of down in both lower quadrants. He's had a colonoscopy before in his history of a polyp a couple years ago. This guy smokes, has hypertension and coronary artery disease. So, could be diverticulitis, right? It's kind of a lot like the last guy. But what else could it be with his past medical history? You could say again. Don't say bladder cancer. He could have ischemic colitis, right? Don't forget about that. Sudden onset of bloody diarrhea in this population of people. They'll get ischemic colitis. And you will not be able to differentiate the two clinically. You have to get a CT scan to see it, okay? They have fever as well. Okay? He's got blood in his stool. So this guy has got diffuse ischemic colitis. He's swollen up. You can see where it will bleed, you know, get still inflamed. So going quickly. Okay. So don't forget about ischemic colitis. Older patients, weird acute onset of bloody stool, but with pain. Where that other lady we saw earlier didn't really have a lot of pain with it, was just happy as a large sitting in the bed bleeding. She probably doesn't have ischemic colitis. This guy's got pain and bloody stool. Ischemic colitis or diverticulitis. And by far, it's going to be diverticulitis more often. But if it's bloody, it could be ischemic. Don't forget that. Okay? Now here we got another guy, 75. 3-hour history of severe abdominal pain. It's constant. In the epigastrium, radiates to the flex. He's not having nausea, vomiting. He doesn't have fever or chills. He hadn't been feeling bad for a couple days. He just started having abdominal pain. We didn't have weird urgent stools. See, this is why this history is important. He didn't have weird, urgent, little bit of blood mixed in with the stool. We just started having really bad abdominal pain. Okay? What else do you want to know about his history? Cardiac? Yeah, you definitely want to know his cardiac history. High blood pressure, type 2 diabetes, coronary artery disease, no prior abdominal surgeries, smoker. What's he got until proven otherwise? Yep. AAA. He's really distressed. His blood pressure lying down is 92/54. What's the key here? Diminished pulses bilaterally in his lower extremities. Okay. Now his belly is obese, so you can't see a pulsatile mass like most Oklahomans. Other people are still. Their belly is out to here. It's like, how do I tell anything? In thin people, pulsatile mass. That's what you'll see on your exam, on your board exam. The triad of AAA, right? Hypotension, right? Anybody know? If they're hypotensive and they come in with abdominal or flank pain, severe, and they have a history of any kind of atherosclerosis at all. Okay. So, this is where ultrasound is extremely helpful. You don't even have to waste time with going get the x-ray tech or take them to x-ray. Just put the probe on and look for the AAA, okay? And this needs an emergent treatment. This will kill you. My sister had one in the ER that was did I tell you about her? It's like a 30-something-year-old woman that came in thinking she had stomach upset. She was rupturing a AAA. Probably has some kind of undiagnosed collagen vascular disease that they don't know about. But it's scary. But just put the ultrasound on there and look. You know, it wouldn't hurt anything. So y'all can look over this later when I send it to you. They need immediate this will kill you. You can exsanguinate very quickly. Okay, last one. 30-year-old woman, sudden onset of abdominal pain at midnight. Woke her up. That's always a bad sign. They woke you up from a dead sleep. Okay. Initially was right flank pain. And anytime it's hurting into the shoulder, what should you be worried about? Something's irritating the diaphragm, whether it's spleen going to the left or whether it's liver or gallbladder going to the right. If they're having abdominal pain that radiates to the shoulders, worry about blood or air or inflammation underneath the diaphragm, right, on either side. Okay. So she says she had a menstrual period a week ago, and she's sexually active with her husband, but what are you going to check anyways? Check the pregnancy test. She's fairly stable hemodynamically. She's got CVA tenderness bilaterally. She got kidney stones in both kidneys? Probably not. Pelvic exam is negative, no cervical motion tenderness, discharge noted. All females with abdominal pain in the ER who are of childbearing age get a pelvic exam, right? But it's really, unless you are really sure it's something else, you need to do the pelvic exam. Good place to get some practice. Generalized tenderness with bimanual exam, but no real chandelier sign, okay? Hemoglobin on admission was 13.8, it's now 11. Checked her urine twice, just to be sure. So she doesn't have an ectopic, and it's negative, okay? You CT her, and choose CT instead of ultrasound, because you want the whole abdomen, right? And she's got pain all up and down. She's filled with fluid, which we suspect is blood. Okay, so she has a left ovarian complex cystic lesion. Okay, so she has ruptured something on that left ovary that's bleeding into her abdomen. Okay, so peritonitis, peritoneal pain up under the diaphragm is going to radiate to the shoulders. So if you rupture your spleen, they can come in with shoulder pain. Okay, if you're bleeding up around your liver, come in with right shoulder pain. This is a rare, weird thing. The take home on this is don't forget that it can be the ovary. The woman has ovaries. Okay. A lot of fluid on the ultrasound. I didn't put an ectopic in here, but this is just a cystic, benign cystic mass that ruptured. Okay? She would have to have surgery. So your question to answer is, do I need a surgeon, right? I can figure that out, figure out if they need fluids, learn how to read a few x-rays. Don't jump straight to the CT. Interpret your labs. You'll make good ER practitioners. Any questions? I'll send this out. Would y'all prefer